Welcome to this comprehensive clinical review of post-infectious bronchiolitis obliterans in children, proudly presented by the Pediatric Case Review channel. Today, we will utilize a case-based approach to master the etiology, pathophysiology, diagnosis, and treatment of this chronic lung disease. Our goal is to provide high-quality medical education for our viewers. Let us begin. Here is our first clinical case. A 3-year-old boy presents with persistent cough, wheezing, and tachypnea for 10 weeks. His symptoms began 2 months after hospitalization for severe pneumonia. What is the most common infectious cause of post-infectious bronchiolitis obliterans in children? Option 1, respiratory syncytial virus. Option 2, adenovirus. Option 3, influenza virus. Option 4, mycoplasma pneumoniae. The correct answer is option 2, adenovirus. Specifically, serotypes 3, 7, and 21 are notorious for causing severe necrotizing bronchiolitis. As shown in the illustration, the viral invasion leads to severe epithelial injury and an intense inflammatory response, which subsequently heals with chronic airway fibrosis. While other viruses can cause this, adenovirus is the most frequently implicated pathogen. Case number 2 examines epidemiology. A research study compares the incidence of post-infectious bronchiolitis obliterans across different populations following adenovirus pneumonia. Which population groups have been shown to have a higher incidence of this condition? Option 1, European and African populations. Option 2, Argentine, Native American, and Korean populations. Option 3, Middle Eastern and Southeast Asian populations. Option 4, Australian and Pacific Islander populations. The correct answer is option 2. Epidemiological studies in the map provided illustrate a significantly higher incidence in Argentine, Native American, and Korean populations. This geographic and ethnic clustering strongly suggests that genetic susceptibility factors, likely involving immune response genes and epithelial repair pathways, play an important role in disease development following a severe viral insult. Case number 3. A 2-year-old girl presents with fixed airway obstruction 6 months after severe viral pneumonia. Her tests were negative for adenovirus. Besides adenovirus, which of the following viruses has also been associated with post-infectious bronchiolitis obliterans? Option 1, rhinovirus and coronavirus. Option 2, respiratory syncytial virus and influenza. Option 3, parainfluenza and human metapneumovirus. Option 4, rotavirus and norovirus. The correct answer is option 2, respiratory syncytial virus and influenza. The diagram shows how a normal bronchiole progresses to end-stage fibrotic changes after severe infection. While adenovirus is most common, respiratory syncytial virus, influenza, and even mycoplasma pneumoniae can trigger the abnormal healing process that obliterates small airways. The severity of the initial injury is the key determining factor. Case number 4 focuses on pathology. A lung biopsy specimen from a child with suspected bronchiolitis obliterans is examined under microscopy. The smooth muscle walls are preserved, but there are significant luminal abnormalities. What is the characteristic histopathological finding? Option 1, alveolar consolidation with inflammatory exudate. Option 2, granulomatous inflammation with caseous necrosis. Option 3, concentric fibrosis with luminal obliteration of bronchioles. Option 4, bronchial wall hypertrophy with mucus plugging. The correct answer is option 3, concentric fibrosis with luminal obliteration of bronchioles. The progression diagram illustrates how subepithelial and peribronchiolar fibrosis narrows the airway. Importantly, the smooth muscle layer is typically preserved, and the distal alveolar spaces remain relatively spared. This targeted obliteration of the small airways differentiates it from parenchymal diseases like pneumonia or tuberculosis. Case number 5. An 18-month-old boy is evaluated 8 weeks after recovering from severe adenovirus pneumonia in the intensive care unit. He has ongoing respiratory symptoms unresponsive to bronchodilators. Which combination of symptoms is most characteristic? Option 1, episodic wheezing with complete symptom-free intervals. Option 2, persistent tachypnea, chronic cough, and progressive dyspnea. Option 3, high fever with productive cough and chest pain. Option 4, nocturnal cough with seasonal variation. The correct answer is option 2. The clinical timeline shows that after the acute phase, persistent symptoms emerge, including tachypnea, a non-productive cough, and progressive dyspnea. These symptoms are continuous, lasting at least 6 to 8 weeks, without the symptom-free intervals typically seen in asthma. The obstruction is fixed, and the patients generally do not have ongoing fever. Case number 6. A pediatric pulmonologist reviews outcomes data and notes considerable variability in disease trajectories among patients. Which statement best describes the clinical course of post-infectious bronchiolitis obliterans? Option 1. Uniformly progressive deterioration leading to respiratory failure. Option 2. Complete resolution with appropriate antibiotic therapy. Option 3. Variable progression with 3 distinct patterns observed. Option 4. Predictable course determined by initial viral serotype. The correct answer is option 3. The graph demonstrates the highly variable clinical course. There are 3 distinct patterns, ranging from slow, steady deterioration to rapid deterioration followed by stabilization to rapid progressive decline. Approximately 20% face severe outcomes, 20% achieve near complete recovery, and 60% maintain persistent moderate impairment. Long-term follow-up is absolutely critical. Case number 7. A 4-year-old boy undergoes a physical examination. He appears comfortable at rest, but becomes tachypneic with minimal activity. His oxygen saturation is 92% on room air. What is the most common physical examination finding? Option 1. Unilateral decreased breath sounds with dullness to percussion. Option 2. Bilateral wheezing with a prolonged expiratory phase. Option 3. Diffuse crackles with bronchial breath sounds. Option 4. Stridor with suprasternal retractions. The correct answer is option 2. Bilateral wheezing with a prolonged expiratory phase. As shown in the breathing pattern diagram, widespread small airway obstruction leads to prolonged expiration and persistent wheezing that does not respond to bronchodilator therapy. Decreased breath sounds, tachypnea, and an increased work of breathing are also common. Stridor or unilateral findings would suggest alternative diagnoses. Case number 8. A 3-year-old girl undergoes a high-resolution computed tomography scan of the chest. The radiologist notes a characteristic pattern of varying lung density, with some areas appearing hyperlucent and others more opaque. What is this classic finding called? Option 1. Mosaic attenuation pattern. Option 2. Ground glass opacities with consolidation. Option 3. Honeycombing with traction bronchiectasis. Option 4. Tree and bud nodules with cavitation. The correct answer is option 1. Mosaic attenuation pattern. The computed tomography images clearly show a patchwork pattern. Diseased areas with obstructed bronchioles appear darker due to air trapping and hypoxic vasoconstriction, while healthy lung areas appear brighter as they receive redirected blood flow. This mosaic appearance is the hallmark radiographic sign of post-infectious bronchiolitis obliterans. Case number 9. A pulmonologist orders both inspiratory and expiratory phase computed tomography scans for a child. What does expiratory scanning explicitly demonstrate in bronchiolitis obliterans? Option 1. Complete resolution of lung abnormalities during expiration. Option 2. Persistent lucency in affected areas indicating air trapping. Option 3. Increased lung density due to atelectasis. Option 4. Dynamic airway collapse with mucus plugs. The correct answer is option 2. Persistent lucency indicating air trapping. The graph and images explain that during expiration, normal lung tissue increases in density as air exits. However, obstructed bronchioles prevent air from escaping, so the affected areas remain abnormally dark or hyperlucent. This accentuates the mosaic pattern and definitively confirms the presence of small airway obstruction. Case number 10. A 5-year-old boy undergoes spirometry. Before bronchodilator use, his forced expiratory volume in 1 second is 55% predicted. After receiving 400 micrograms of albuterol, it is 57% predicted. What pattern is this? Option 1. Restrictive pattern with reduced total lung capacity. Option 2. Obstructive pattern with minimal reversibility to bronchodilators. Option 3. Mixed pattern with proportional reduction. Option 4. Normal spirometry with isolated reduction in diffusion capacity. The correct answer is option 2. An obstructive pattern with minimal reversibility. The flow volume loop illustrates a classic obstructive curve. The lack of significant improvement after albuterol, typically less than 12%, confirms that the airway obstruction is fixed. This physiological finding is crucial for distinguishing post-infectious bronchiolitis obliterans from asthma, which features reversible airway narrowing. Case number 11. A pulmonologist must decide whether to proceed with a surgical lung biopsy or rely on clinical criteria to diagnose a 2-year-old child. What is the standard approach for diagnosing this condition in children? Option 1. Lung biopsy is mandatory for all suspected cases. Option 2. Clinical diagnosis based on history, symptoms, pulmonary function tests, and computed tomography imaging. Option 3. Bronchoscopy with bronchoalveolar lavage is diagnostic. Option 4. Positive viral serology confirms the diagnosis. The correct answer is option 2. The diagnostic algorithm shows that a clinical diagnosis is standard, utilizing a history of severe infection, persistent symptoms for over 6 weeks, fixed obstruction on pulmonary function tests, and a mosaic pattern on computed tomography. Lung biopsy is highly invasive and prone to sampling errors, so it is reserved only for cases where the diagnosis remains uncertain. Case number 12. A 4-year-old presents with chronic wheezing. The clinician must differentiate between post-infectious bronchiolitis obliterans and severe asthma. Which computed tomography finding best helps distinguish between the two? Option 1. Presence of mosaic attenuation on inspiratory scans. Option 2. Bronchial wall thickening and mucus plugging. Option 3. Bronchiectasis present in 88% of cases. Option 4. Mediastinal lymphadenopathy. The correct answer is option 3. Bronchiectasis. The comparison table highlights that bronchiectasis, which reflects chronic structural airway damage, is present in 88% of children with post-infectious bronchiolitis obliterans, compared to only 29% with severe asthma. A history of severe infection and a lack of bronchodilator response further separate this condition from episodic asthma exacerbations. Case number 13. A 2-year-old boy is diagnosed with the condition 2 months after adenovirus pneumonia. His oxygen saturation is 90% on room air. The physician initiates anti-inflammatory therapy. What is the recommended corticosteroid regimen? Option 1. Daily oral prednisone at 1 mg per kilogram for 6 months. Option 2. Inhaled fluticasone alone twice daily. Option 3. Intravenous methylprednisolone pulse therapy 10 to 30 mg per kilogram for 3 days monthly. Option 4. No corticosteroids recommended. The correct answer is option 3. The treatment timeline illustrates the use of intravenous methylprednisolone pulse therapy at 10 to 30 mg per kilogram per day for 3 consecutive days, repeated monthly for 3 to 6 months. This approach aggressively targets the inflammatory phase while minimizing the severe side effects associated with prolonged daily oral corticosteroids, such as growth suppression. Case number 14. A 3-year-old girl has completed 6 months of pulse corticosteroid therapy with modest improvement. The pulmonologist considers adding long-term azithromycin. What is the recommended dosing regimen in children? Option 1. 5 mg per kilogram daily for 2 weeks only. Option 2. 10 mg per kilogram 3 times weekly for long-term use. Option 3. 20 mg per kilogram once weekly. Option 4. Azithromycin is contraindicated in bronchiolitis obliterans. The correct answer is option 2. 10 mg per kilogram given 3 times weekly. As shown in the mechanism of action diagram, azithromycin provides significant anti-inflammatory and immunomodulatory benefits beyond its antimicrobial effects. It reduces neutrophil accumulation and inflammatory cytokines. This intermittent dosing schedule provides sustained tissue levels while minimizing gastrointestinal side effects during long-term management. Case number 15. Parents of a newly diagnosed 2-year-old ask about their child's long-term prognosis. They want to know if the condition will improve, remain stable, or worsen over time. What information should be provided? Option 1. Complete recovery is expected within 1 year with appropriate treatment. Option 2. Variable outcomes with 20% severe progression, 20% recovery, and 60% persistent impairment. Option 3. Uniformly progressive course requiring lung transplantation. Option 4. Excellent prognosis with no long-term complications. The correct answer is option 2. The prognosis chart shows that outcomes are highly variable. About 20% experience severe progression, 20% achieve near complete recovery, and 60% are left with persistent moderate impairment. All patients require lifelong pulmonary follow-up, regular spirometry, oxygen monitoring, and strict adherence to vaccination schedules to prevent further irreversible lung damage. I would like to personally invite you to join our growing community on Patreon, named Pediatric Case Review. This community contains all of our videos conveniently arranged by physiological system for easy access. All the presentations used in our videos are available as downloadable files so you can easily review the material and practice the questions. For subscription details, please comment below and we will message you. Thank you for participating in this comprehensive clinical review of post-infectious bronchiolitis obliterans in children. We hope this case-based lecture has enhanced your diagnostic skills. Please subscribe to the Pediatric Case Review channel for more high-yield, evidence-based medical education. If you have any clinical questions, please leave them in the comments below. Thank you for watching.